Hi, Jack. I'm back. I'm out of my party clothes. The election party ended. I shaved. I got a little bit of a haircut. It's a new day. I'm feeling good. I spent the day today, Sunday, in the bright sunlight here in Portland, Oregon. Beautiful fall colors. Everyone's happy here finally. And I was happy to sit down and troll around the room now in ACR. There's a lot of cool stuff going on. So um, I wish I was there like everyone else, but I'll tell you what I found today that was interesting and make a few comments. First, about steroids. Dr. Hanley from Halifax presented some nice data, poster abstract 1014, looking at corticosteroid use in Canada among elderly individuals, patients over age 65 with RA. Surprising, well, maybe not surprising. Corticosteroid use is quite common. I was surprised, though, to see that the bulk of the prescription use there, at least in Canada, was prescribed by primary care doctors and not the rheumatologists. Only about a third of it was by the rheumatologist. Suffice it to say, which was interesting, that even though there's been this great uptake of biologics and small molecular therapies there over the years, which we all know are steroid sparing, almost every molecule has a study showing that when patients start them, they're able to wean their dose or get off prednisone. So we know there's good steroid sparing data with most of those agents, or really all of them. But looking in the real world, the population wise in Canada at least, we see the uptick of those therapies, yet the use of corticosteroids has been largely flat. About 30% of RA patients over this time period have stayed on or have used corticosteroids. Now, the good news in the data showed a decrease in the total dosage patients were using and the decrease in the duration of each prescription. So I think there's some good signs there. It sounds like people are trying to wean corticosteroids. But maybe the message also needs to get to the primary care doctors. And that's what I took home from that. And obviously, this is going to vary upon region and where you are in the world and how you practice. But it's looked like from that data that rheumatologists are getting that message and acting on it and trying to reduce steroids. And so maybe we need to talk to other groups as well that care for these patients. So I transitioned to a really nice study that was just published in the Annals of Internal Medicine. And the nice thing about that is I think a lot of internists do read it, and family practice docs, primary care doctors do read it. And this was Mike George's work, who's an outstanding young researcher from UPenn. And I was privileged to work with him on this project as well as several others. But we looked at Medicare and Optum data in the US and looked at the harms of even low-dose steroid use. And this is well-known stuff. However, most of our observations studies when we look at steroids are often confounded by the fact that patients on steroids have higher disease activity. And so the best we can do, we control for it in all these studies the best we can. But unless we have good, discrete information on disease activity, we can't really control for it. So the beauty of that study is Mike did it. And he used TAC scores and inflammatory markers in a subset of these patients, was able to show that even when you control for those things, low-dose steroids on their own are a risk factor for serious infection. And the rates of infection at 1 year time, it was something like 5 to 12% of these patients, depending on the database, would be in the hospital with a serious infection, even at lower doses of steroids. So I think the message is clear to me that we need to keep working on this. We probably need to reach out to other types of physicians. I guess the point of that was I got emails and calls from friends and colleagues that were primary care doctors who said, hey, this is great. I don't normally read about this stuff. Thanks for putting this out there, because a lot of us think low-dose steroids probably aren't that big a deal, or a lot of us see our patients on them or we use them. So anyway, I think we're moving in the right direction. That being said, I want to just point a few other things out, because I think we're moving in the right direction with vaccination. I know there was a lot of talk today and I think tomorrow about COVID vaccine development, which I'm not going to comment on. But I'll comment on the fact that I'm using the idea that we are likely to have vaccination for COVID next year. I'm using that as a reason to make right now my vaccine moment, meaning, it's time to get vaccinated for everything else, because getting a COVID vaccine on its own is going to have all sorts of questions surrounding it, how to do it, when to do it. So why not get your vaccines that you need done now? Shingles vaccine, pneumococcal vaccine, influenza vaccine. Obviously, prioritizing the respiratory infections right now. It's influenza season. This is something we need to do. Just highlighting a couple things presented yesterday. Abstract 632 and 634 on Saturday had to do with vaccine hesitancy and barriers. One of the biggest reasons patients don't get vaccinated. This was a peds practice. Rheumatology was lack of efficacy or perception of lack of efficacy. The other study, 632, this was Dr. Colmegno's study in McGill, a large adult room population. And they found that again, questions of efficacy were or lack of efficacy were associated with a strong chance that the patient would refuse the vaccine. Today, Dr. Horomansky from Stanford, they surveyed refusers and acceptors of vaccines, and this is number 1135 today, Sunday. And a lot of people, as you know, you offer the flu vaccine, they say they get sick from it or they had a bad experience from it before. So those are the things we try to overcome by saying, hey, the vaccine's a lot different than it used to be, or it's better tolerated, or we give it differently sometimes in some cases. So there's various ways to deal with these problems that come up. And one way is showing effectiveness and efficacy. And I'm just going to park it right there because tomorrow that's what we're going to do. We're going to focus on vaccines and some of the data presented at ACR talking about effectiveness and efficacy. I think that's important, as clearly the data presented today highlighted the lack of efficacy or perceived lack of efficacy of many of our vaccines that drives some vaccine hesitancy. So I think those types of studies that show effectiveness are important. And I'm happy to see some of that work here at ACR. And what else am I going to talk about? Oh, yeah, we'll get back into JAKs. We'll get back into herpes zoster and zoster prevention. There's a lot of cool stuff on Monday and Tuesday this week. So I'll sign off now. Have a great night and enjoy ACR. Cheers.